Firstly, I would like to thank all the organizers. Professor Saak Saab, thank you for the invitation. General Saab, how are you? I hope things are good. नहीं बात हो गया इतने में काफ़ी है. अच्छा जी, घड़ी किसी के पास है तो अल्लाह खैर करे. So, diagnosis of hypertension. There are a few disclosures, and as I will proceed, I will disclose them. Don't want to destroy everything. And of course, there's no relevant conflict of interest regarding this presentation. So when do you suspect secondary hypertension? Abrupt onset. Suddenly something starts going wrong. You are too young. It is not expected that you are going to be hypertensive, yet it hits you. You are 55, you think that you have been lucky enough, and then next thing you know, it hits you. And suddenly, everything becomes wrong. And before you know, your ophthalmologist also says, please look after yourself before I start doing anything for you. Previously was controlled, but is no longer. Suddenly, things have gone wrong. Poorly controlled, despite the fact that the patient is on 3 or 4 or even at times 5th drug, yet it is not working out. Recurrent flash pulmonary edemas. We normally don't associate it, but that is where it hits you very badly. Hypotension with unexplained renal insufficiency. Presence of features like hypokalemia, renal bruise, of course, what you know, what I'm going towards. And when you're doing it, what we must look for? We may be able to treat it. Primary aldosteronism is something that you say that may be treatable. Obstructive sleep apnea syndrome. We don't give it too much importance, probably because there are not that many number of patients around us. But if you reality start looking around you, there's plenty of them. Renal parenchymal disease may even be because of a premature birth. The patient doesn't have enough nephrons in it. So if you're born someone who's been lucky to survive a 7-month delivery, may gradually develop into hypertensive. Renal artery stenosis is something that everyone loves to talk about. Pheochromocytoma, a tumor. Major vessel obstructions, don't ever forget them. There are a lot of them coming up in various interesting ways. Lack of sleep. There are people I've seen, and I'm sure you have all had the experience of that. They said that they're okay, but suddenly they have gone into an executive position or something like that, or something has happened in their life, and their sleep patterns have changed. Their eating habits have changed. They have been posted out, must be something common with the military. You get posted out and suddenly you start eating high salt diet and you're a senior ranking officer and things start going wrong for you. And never to forget this last one. You may not be prepared for the talk. So this talk was actually all prepared yesterday night and everything went on. So I thought I'd rather than going into the old standard gloomy things that this is what secondary hypertension is, so let's talk about some patients. This is an 18-year-old girl. She came with history of headache, palpitations, tremors, insomnia. On examination, anxious young girl. She was not at all comfortable. History of fluctuating BP with massive variations. Thin, weak, with a pulse of about 110 at that moment. We looked at her referral slips, and her BPs was being read as 180, 120, 120, 170. So there was plenty of evidence that things have not been on the right side for her. By the way, her echo was also not too good. She had a poor LV. And BP recordings by us on the right-hand side was 140 by 90. Any takes so far? So we thought that it may be a pheochromocytoma. We started looking towards that direction. So basic blood pictures were done. She was anemic, slightly hypoglycemic. Something which really was pointing towards anything. Electrolytes were normal. Urinary VMA was negative in this first go. Requested for abdominal ultrasound, and then also for a CT, and then an MRI. The standard protocol. We had a diagnosis by this time, and just for the hell of it, we also thought let's do an MEB also over here. And we did a repeat urinary VMA. And this time, ladies and gentlemen, it was positive. This is an article that me and my colleagues, I was the junior most at that time, so you see my name at the end. You see the familiar names of Dr. Ayub over there, Mohsin Nazir over there, Tayyib Pasha, Iqbal, and all of them. They contributed into this paper, and this was published in the Annals. And this was back in 2001. So that is when the affairs with the hypertension sort of started off for me. And you can see over here, it clearly states that there were 6 patients, and of them, majority were ladies, and of them, in majority, VMA was negative. And the diagnosis, ladies and gentlemen, comes from the ultrasound. Because at that moment, someone suspected and asked Dr. Jamil, who was the ultrasound person, who was doing all of these studies, to please be very careful in noting these things. And I'll just share some of these images that you will see in this paper. This is the ultrasound over here, and it shows this thing. This is the CT, and over here is the MEB scan, which said that things are. So pheochromocytoma, something can be managed. She was later on referred off to a surgeon who operated on her, and of all these 6 cases, they were all operated, and they all did well. Patient 2 came to emergency with severe shortness of breath, chest discomfort, not a diabetic, BP is 210 by 140, ECG V1, V4 is ST elevation. So the first thing, of course, is go after, control the blood pressure. They gave him also furosemide, probably because there were some crepes in the chest or something like that. And then once the BP was slightly better, the patient was shifted into the cath labs for a primary PCI. And a proximal to mid-LED PCI was carried out. Patient examined now again. Fluctuating BP, sinus 70-80, sleeping with loud snoring. It is very difficult to wake him up. You're trying to wake him up to ask him how things are, but he was snoring away. Hardly a neck, hardly a neck. Everything is hanging around. And 150 kgs, 5 feet, 7 inches. So, any takes? That's where you are. That's what it is. So now how do you want to manage this patient? Standard post-PCI treatment? Of course, that has to be done. What about this? Do you want to give him this surgery? At this stage? When? Basically, you don't want to give surgery because he is on all of these dual antiplatelets. You don't want to take a risk because you know things have gone wrong. So you start sitting down with these people and you counsel them. And the people who need to be counseled most is the family. मेरा पुत्र कमज़ोर हो गया है एक स्टैंडर्ड स्टेटमेंट मिलती है हाय हाय डॉक्टर साहब तुसी की कर देता है चंगा भला सोना सी reality is they are all obese family usually ਇਹਨਾਂ ਦੇ ਘਰ ਵਿੱਚ ਦਾਣੇ ਬੋਤੇ ਨੇ and that is where the problem lies and they all the family needs to be sit down and to be counseled out. CPAP is an option, of course, if they are into that kind of a condition, but it's always a tricky thing. It's an uncomfortable device. But if you can get used to it, it can take you through. Anyway, for this person, a massive exercise was done, 30 kgs weight reduction was carried out, and this has led to a better BP control, but still not the ideal one. Patient 3, 58 years old gentleman presents with a history of palpitation. On inquiry, it is noted that he has asymmetrical hypertrophy of LV, more of the apex. He shows us his echocardiograms. And thus, he is on verapamil 120 prescribed by an electrophysiologist. On examination, there is systolic murmur over A1. Heart rate is about 90. His sitting BP at that time, left arm is 170 by 100, right arm is 130 by 80. Any takes? Coarctation, 1. Any other takes? This became interesting, sort of, because normally you say that the left arm is 10 less, right arm is 10 more. Doesn't make much of a difference. And the patient over here starts saying that patient claims his BP was checked by digitally himself on left side, because it is easier to put it on the left side always. And it was never raised. So this is what the CT scan shows. Those of you who have the eye for it may be able to see something. I thought I'd give you the raw image first and then go to the refined images that we normally see. If there's any CT man over here, they may be able to pick up. So rather than wasting, this is what it is. Look at this. This is our my CT department doing this trick for me. Can you pick it up over here in this view, which is the one which is rotating around? And if you look over here, in this one, the clavicle is now digitally removed, not physically, of course, and there it is. Thoracic outlet, subclavian. Normally you say it's on the left side because that's what the commonly seen is an extra rib or something, a fibrous cartilage over there. But this one was it's an interesting one. So did images are deciding what next to be done. If you look at this vessel over here, it has these spots. This vessel, while on the left side, is totally clean, but the disease very much exists over here. And if you do the dimensions measurements, it is more than 50% diameter-wise it's crossed, and the disease is there. So, any takes, what to do? What next? On that table. So the next thing that I wanted to know was that is this being compressed by the bones also? Because if I place a stent over here, will it make a difference? Will I create a problem for him? So at the moment, these things show that it probably will not. At the moment, I've started up on a calcium channel blocker, and hopefully that may be of some benefit to the gentleman and may move out from there. Patient 4, this is a very interesting case. We have been following her up for last about 10 years. She is Takayasu's arthritis, and unfortunately, her condition worsened, and she had a left main disease. At that moment, the surgeon decided that a bypass needs to be placed, so a direct Lima graft was placed on the LAD, no graft was placed on the circumflex. I don't blame him. I think he did the right thing because the way the whole aorta was calcified, it was probably the best thing to do. Anyway, later on, she was just 18 years old, and later on she came in with left main problems. She came in, for which we have done so far twice an angioplasty on her left main, and she does well after that. After the first angioplasty, she started having hypertension. And at that moment, I gave her treatment, and I did this. If you can see the stent in the background, we did this angioplasty of placed a stent over here and onyx over here. But a few years down the road, she developed the osteal disease of the left main again, and in the same sitting, we did the left main osteal setting, and since that was not the topic, so I've deleted those slides, and we went after this one. Then we placed in the wire, as you can see on the next slide, and after that, we got hold of a balloon. This is about 4 years old slide, by the way. And we went after it, and we gave it a big yank. This is with a 512 balloon that we gave it. After the yanking was done, we didn't think that it was appropriate. And we did a view, and the view showed a reasonably good result. Initially, there was a pressure damping, but there was none over here. Unfortunately, my IVUS images of this are lost, but she also had the same thing on the right side. At this moment, she was on 4 drugs. BP was still at 200. She would come in with flash pulmonary edemas. So that was the reason why it had to be done. Since then again, we ballooned it up. After ballooning it up, this is the IVUS image that was saved. These are the images over there after the ballooning, and you can see the 4, but we felt there is a bit of a dissection over there. So we decided to place a stent over here. So now an Onyx 515 was placed and was pulled back the balloon and was up yanked. And this is the result we had. And again, an IVUS analysis was carried out. And these are the IVUS results for you. And this is that. After this, for the last 4 years, her blood pressures are better controlled. I have repeated this angiogram, and she is, as far as this is concerned, is okay. As far as the left main is concerned, I was afraid at a certain stage it may not be right. So left renal artery is like this. Case 5. I hope I've got a minute. Time is up. Just give me a minute now. I'll be quick. 23 years old man, fatigability, could never run out his friends and would get short of breath. Referred by a friend because of his chest felt funny and vibratory. Examination, cheerful young man, but slightly overwhelmed by the hospital. BP 180/90, both arms. Any takes? Any takes? Radiofemoral delay easily. I hope now you have your answer. So, echo was done, and after the echo, we went in, and this is where Dr. Asif Rahman, our head pediatric cardiologist, his disclosure comes in, because this has all been done by him. So, we cross, and then the implants of wire, the dilator, the sheath, all are in. Then comes on the other side, the stent gets placed in, and once the stent is placed in, it is adjusted out. And if you notice over here, the proximal part of the stent is not deployed, while in this one, the proximal part is deployed. This is because which site it is, so at times they need to anchor it before slightly and then go accordingly. And there you see the dilatations taking place. Dilatations completed. And then the results were taken, and from a 70-80 pressure difference, it drops down to about 15. So what does this lead to? 25% or more are cured of hypertension. Hypertension management becomes better. Lesser number of drugs are needed. And probability of coming back with a heart failure goes down. Ladies can consider pregnancy, which is most important. And earlier you treat, the better it is. They are even doing it in the children. And of course, at that stage, it's ballooning. And with this, I thank you all, and I share this video and remind you all that smoking causes hypertension. And the only way to treat that is if you look after yourself and quit it. Because other day, something like this may happen with you, and then you may turn around and say, I wish I had quit. So enjoy this video. It's 5-10 seconds more. Assalamu alaikum. They say that if you quit smoking from 10 cigarettes to nothing, you can get rid of about 10 to 15 millimeters of mercury of pressure. You know what leg rubbing means, but anyway. A lot of symbolism. Symbolism is there. And she walks away. Mind you, it causes not just hypertension, it also leads to impotence. Thank you. Have a great day.